Hello and welcome to MRSi Talks ART, the latest advances of IVF. I am Dr. Angie Beltsos, founder and executive chair of the Midwest Reproductive Symposium International, MRSi. Our podcast is dedicated to experts providing single subject exploration into the advances in IVF. Thank you, Fairing Pharmaceuticals, for your continued commitment to education by sponsoring this podcast. It is my pleasure to introduce two talented and experienced doctors to our podcast. First, our guest, Dr. Rachel Wienerman. Dr. Wienerman joined University Hospitals in 2015 and has been the program director since 2021. She is a physician scientist with an interest in the effects of clinical manipulations used in assisted reproductive technologies on neonatal outcomes. Then, joining Dr. Wienerman today is Dr. Gigi Collins, who is a reproductive endocrinologist and infertility specialist, a graduate of Loyola University Stritch School of Medicine, where she also completed her residency. Dr. Collins is a board certified in OBGYN and reproductive endocrinology doctor. She completed her fellowship in REI at University Hospitals, Case Western Reserve Medical Center. Dr. Collins is also serving as the current president of MRSi. Dr. Wienerman will be exploring endometrial lining and receptivity. Welcome to you both.
Good morning, everyone. This is Dr. Gigi Collins. I am very excited to be here doing the MRSi podcast series with Dr. Rachel Wienerman. Dr. Wienerman is a friend, a colleague, and a mentor of mine. And today we are going to be discussing the thin endometrial lining, which some might say is kind of the dark horse of reproduction. We talk a lot about the ovaries, but the endometrium kind of gets ignored until we have an issue. So our objectives today are we are going to discuss the workup and treatment of thin endometrial linings. We are going to try to understand clinical success rates of the thin endometrial linings and different linings and preparations that we use. And we're going to describe management options for fluid in the endometrial lining as well. With that, I have no disclosures. Welcome, Dr. Wienerman. We are excited to have you on the podcast.
Thank you. So excited to be here. I would say former fellow, but really mostly colleague and friend, and just very excited to be talking about this with you today. And I also don't have any disclosures.
Awesome. So just bringing it back to when I was your fellow, I am going to present a case this morning and then ask you a series of questions to see how you would manage it and if you have any evidence to back up the answers that you have. Because as we know, sometimes in REI, we don't have great evidence to back up what we do, so we rely on expert opinion, and there is no greater expert than Dr. Wienerman. All right, so let's kick it off. We are going to be talking about a 34-year-old G0 who presents with primary infertility. Only thing really notable in her history is that her cycles are irregular. They come about every 3 to 6 months if she's not taking Provera or any other form of cycle regulation. Her workup noted a normal appearing uterus with a endometrial stripe of 3 millimeters. Ovaries were polycystic in appearance bilaterally. She did an HSG, patent tubes, normal uterine cavity. Her laboratory workup noted a normal A1C, TSH, elevated total and free testosterone, and her AMH was 7. Semen analysis was normal. Carrier screening was negative. Is there anything else you would do to work this patient up at this point?
So first of all, let me say that this is a very familiar type of patient. And I think we probably all see patients like this, but I would say if I am concerned about her irregular periods and elevated testosterone, I might want to evaluate that a little bit more just to rule in the diagnosis of PCOS by ruling out other causes. So I might rule out congenital adrenal hyperplasia by getting a 17-hydroxyprogesterone and then probably a DHES to look at other sources of androgens.
Okay, great. And both of those were done and they were negative. So at this point, what would your working diagnosis be for this patient and her primary infertility?
Since she does have irregular periods, elevated testosterone, and PCO appearing ovaries, and we've ruled out other sources of her androgens, then I would give her the diagnosis of polycystic ovary syndrome, which she meets because she actually meets all three of the Rotterdam criteria that we utilize, which are the oligomenorrhea, the elevated testosterone or signs of elevated testosterone, and then the PCO ovaries, which, depending on your ultrasound definition, could be either more than 12 or 25 follicles per ovary.
Okay, great. And so what would you talk to this patient about initial management? What are you thinking?
So for me, she has a diagnosis of polycystic ovary syndrome. Everything else has been normal. She is not ovulating. So what we would need to do to help her conceive is get her to ovulate. So I would recommend letrozole with timed intercourse as the first line treatment for her. And we know that letrozole has been shown to be more effective than Clomid in these patients in a randomized controlled trial, which is called the PPCOS2 trial.
Okay, great. And when you do these types of cycles, Rachel, do you monitor those patients or do you just say, here's letrozole? Do you check a day 21 progesterone? How do you manage those cycles?
So I actually have a more conservative, I would say, approach. Actually, for a type of patient like this, I might not even get a semen analysis or an HSG right away. If really, there's irregular periods seems to be the main source of the difficulty conceiving. I typically give them letrozole without monitoring for 3 or maybe even 6 months, depending on the patient's age. I do get a day 21 progesterone level to ensure that they've ovulated. But other than that, I typically do not do monitoring.
Okay, got it. Um, and when you choose a dose of letrozole, how do you know what dose to start with?
Excellent question. I would say when I first started in my career, I really tried to mimic my rules for how I used to do clomiphene citrate and give the lowest dose to start and then titrate up if I needed to. So the lowest dose is 2.5 milligrams and then go up to 5 milligrams or even 7.5 milligrams. I think some patients do respond to the 2.5 milligrams, especially if their BMI is normal. However, if the BMI is higher, I typically start at 5 milligrams because I've had a lot more success with those patients instead of having to have that frustrating month of not responding to the 2.5.
Fair enough. Um, do you ever find, when you meet these patients, do you find that maybe it's beneficial to walk the patients through all of the testing options and say, if we are working you up for fertility in general, these are all of the tests we would do. But in this clinical situation or scenario, it doesn't seem you have to do all of those. But forewarning, lightning can strike twice, and it could. Right now, we are just thinking your issue is oligomenorrhea, and we need to get you to ovulate to conceive. But as we all know, as you start progressing through fertility treatments, that changes. And so I think some patients actually want all of that information up front so they know, okay, the sperm is, they know all of the other pieces. And then I think other patients are more reticent to that. So do you find, because I tend to do this now, but it was a change in how I practice as you learn that sometimes getting all of that information, well, it is maybe helpful for some patients.
That's an excellent point, and I think that my practice has evolved too. I think that when we started, and Gigi was our fellow at Case Western, so we have a patient population there, a lot of whom did not have insurance coverage for even for treatment, sometimes even testing. A lot of people are very hesitant to do anything that's not absolutely needed. And I think for that patient population, having the mindset, yes, we can actually help you without making you pay for all of these expensive testing can actually be really helpful. But then you have another set of patients who are the opposite, right? They want all the information as soon as they can get it. And the more information they get, the more helpful they feel it is for them. And they don't want to do anything until they know everything. So I think there are a lot of patients like that. And I think it's very important at that initial visit to assess what's going to be most helpful for that patient and give them those options. So I agree. Some patients do want the testing, and I definitely offer it. But I just want to make treatment as accessible as possible. So for some people, that might mean foregoing the HSG or the semen analysis and allowing them treatment in order to conceive without spending the money that they may not have.
Yeah, and I think that's reasonable. And I do the same thing. I just let them know, hey, we don't know if your tubes are open, and you may go through this for a couple months and ultimately find that out. So if that is stressful to you, maybe it is worth the money if it's in a non-mandated state. Okay, so your patient does this. She does 3 cycles, timed intercourse. She's ovulating. We know that this is working from a medication standpoint and an ovulatory standpoint, but she's still not successful. And she now comes back to you and says, I want to be more aggressive. What would your next steps be at that point?
Fortunately, in this case, we've already done the semen analysis and the HSG. So we know that her fallopian tubes are patent and we know that the semen count is adequate. Sorry, the sperm count is adequate. So in that case, I would offer her intrauterine insemination combined with the letrozole as the next step. And then this gets to the question of monitoring. She can tell me, if she uses ovulation predictor kits and they're working for her. But I would say for a lot of our patients with polycystic ovary syndrome who may have baseline elevated LH, those kits might not be accurate. So I think in this situation, a patient of this diagnosis and type most likely is going to do monitoring with her IUI cycles.
Yeah, I think it's also helpful to do the monitoring because a lot of times these patients don't respond. Now, she responded to the dose because she did timed intercourse, but let's just say you didn't. I think it's really frustrating for patients when, you wait for the day 21 progesterone is negative and then you're just trying to evaluate. It's just loss in time for a lot of patients. So I think that's, at this point, it's nice to add that in for these patients. Okay, so she comes in, yay, she has a single dominant follicle. Thank heavens you didn't overshoot. But also her endometrium was only 4 millimeters on the day that you triggered her. Talk to me a little bit about, are you talking to her about her thin lining? Are we canceling because of her thin lining? Why does she have a thin lining? What are your thoughts there?
That's a great question. And I think that sometimes with one cycle, we don't really know if this is the patient's baseline or if this is just maybe the follicle developed too quickly for the lining. But I think it is interesting to note that when she came in for her baseline scan, you mentioned that her lining was only 3 millimeters. Now she's not ovulating. So you don't know where she was in the cycle, how much estrogen she had been exposed to at that point. But with letrozole, sometimes patients do get thin linings just because the estrogen level is so low. So for some people, that's not enough to get their lining thicker. Now, the question of cancellation is interesting. I think we've discussed this in my practice for many years. And the question is always, okay, what is the cost benefit for the patient of moving ahead versus canceling when you see a thin lining? This came up a lot when we did, or it still does, when we do a lot of clomiphene citrate IUIs, where we know that this effect of the clomiphene, because it's a selective estrogen receptor modulator, can have a negative effect on the endometrium and cause it to be thin. So sometimes we'll actually switch patients to letrozole in those situations because of that thin lining. When you have a thin lining on letrozole, it's a little bit more challenging because you know that switching them to Clomid is most likely not going to be helpful. So fortunately, we actually have some really good data to guide practice in this situation. And specifically, there was a recent publication that looked at the AMIGOS trial. Now, the AMIGOS trial was a randomized controlled trial, multi-center through the Reproductive Medicine Network that randomized patients to either clomiphene citrate IUI, letrozole IUI, or gonadotropin IUI for unexplained infertility. And what the study that looked at the secondary analysis was published in Fertility and Sterility, and it looked at the success rates in each group based on endometrial thickness on the day of trigger. And what they found was that overall success rates were higher the thicker the endometrium, and specifically even above 13 millimeters actually gave the highest success rate. So it was only about 3.6% of patients got pregnant with a lining less than or equal to 5 millimeters, almost 8% when the lining was 6 to 8 millimeters, about 10% when it was 9 to 12 millimeters, and over 12% when it was 13 or more millimeters. Now, in this case, we don't have the luxury of her having 13 millimeters. And so, but what's interesting is that when they did the statistical analysis, they actually couldn't separate whether the lining was what led to the difference in success or the treatment itself. Because in that study, FSA, or they actually were doing Menopur. So gonadotropin IUI was more effective than clomiphene citrate or letrozole. And so it's very challenging statistically to say, okay, was it the lining or was it the treatment that caused these higher success in certain cycles? So they actually concluded from that study that it probably was not worth canceling for any thin lining because you still had appreciable success rates, and IUI never has that high a success rate. So you still had some success regardless of the lining. And specifically in letrozole, actually, the lining had less of an impact than it seemed to have in the clomid or gonadotropin cycles. Again, none of them reaching statistical significance. And they actually found that when the lining was less than 5 millimeters, there was still about a 5% chance of success with the letrozole IUI. Now, that may seem low, but right, letrozole IUI is never going to be more than like 8 to 9% successful, even in the best of circumstances.
Now, do you
And
ever
again, this is all for unexplained infertility.
Right. Yes. Now, do you ever add any estrogen in the second half of the cycle? Do you ever try to compensate that way? Or do you just say, let's just see what happens?
That's a great question. I'm not a big fan of adding estrogen into a letrozole cycle because I never know exactly when that estrogen is not going to have a negative impact, right? Because the whole idea of letrozole is that we're reducing aromatase, we're lowering estradiol levels. And then when you add back estrogen, you're going to counteract the effects of the letrozole. So if you add it back too early, then you're going to prevent the patient from continuing to have their follicle grow. So I personally don't like to add estrogen. I think that this is the way that this patient responds to letrozole, and either she'll have success with it or not. And I'd much rather move on to other treatments, whether that's gonadotropin IUI or IVF, where we have more control over how we, manipulate the lining for a frozen embryo transfer, rather than adding things to letrozole. But curious what your practice is.
Yeah, I agree with you. I wouldn't do it in the initial phase, but potentially in the luteal phase, just because it's not going to hurt, right? So whether or not it helps, I don't know, because we're not usually monitoring lining at that point anyway, but it's inexpensive and at that point probably wouldn't hurt. So just a thought. Okay, so she doesn't get pregnant. We do this a few more times. Every single time her lining is not breaking 4 millimeters. So what are her other options? At this point, it's not just a one-off, cycle, or maybe it's dependent on whoever was the person doing the ultrasound, right? Because that can sometimes, we all know, change how we read these ultrasounds. So what else would you be talking to her about at that point?
So it's interesting. I've tried various things over the years. I've had many patients in this situation. I've tried putting them on estrogen therapy for like 3 or 4 months at a time, just to see if maybe that will help sensitize the endometrium to estrogen. Maybe that will help increase the success. And typically, I've not had success with that route. I think if this is the way their lining is on letrozole, this is the way their lining is going to be on letrozole. And so I would offer her gonadotropin IUI. We do know that tends to have a thicker lining because you are increasing the estrogen. And unlike letrozole, you're not decreasing the estrogen. Unlike clomiphene citrate, you're not having a negative impact on the estrogen receptor. However, risks of multiples are unacceptably high in gonadotropin IUI cycles. So I really try to avoid doing them unless the patient really understands what those risks are and thinks that IVF is not an option for them. Either for cost reasons, ethical reasons, or they're just not psychologically ready. But I would recommend IVF for this patient. I mean, she's done, all the things that we would say leading up to it. She's done letrozole time to intercourse. She's done IUI cycles. And in the absence of wanting to increase her risk of multiples with a gonadotropin IUI, I would say IVF would be her best option.
Okay. Yeah, and she agreed with that statement. So she underwent IVF, did an antagonist protocol. We got 18 eggs, 14 mature. We froze 8 good quality blasts. She did elect to do PGT, and 5 of them were euploid. Okay. Now we're at the frozen embryo transfer part of this. How would you prepare her for her endometrial or for her embryo transfer?
So I always have this question with patients when the lining is thin, and I know that the lining is thin going into their cycle. But typically I say I always want to see what a patient does by supplementing estrogen. So for this type of patient, I would start with a standard programmed frozen embryo transfer cycle where we give estrogen replacement. We use 6 milligrams of oral estrogen in my practice. Sometimes I'll use patches, if they're not responding. And we'll also use vaginal estrogen, vaginal estradiol, added at the lining check if the oral estrogen is not sufficient. So that's what I would do. I would do a programmed cycle with oral estradiol. And then when she comes in for the lining check, if I'm not happy with her lining, I would add some vaginal estrogen.
And if you're not happy with her lining, you would then also add in patches, or would you transition out one of the oral or vaginal?
So if I was not happy with her lining after many days of estrogen and both oral and vaginal, and I would give her more time, so like typically we have them come in for a lining check after 12 or 13 days of estradiol. I would consider extending that even for another week to see if maybe longer duration would thicken the lining. But if it really doesn't get to a point that I'm happy with, at that point, I would cancel the transfer. I would say, okay, we know how thick you got with, a program cycle. Let's think about other options.
Okay. Would you ever add in IM estrogen? And when you canceled, well, we'll start with that question and then I'll keep probing you.
I actually do not use IM estrogen in my practice, but I'm curious if you do.
I do. And I honestly find that for some of the more refractory patients, it works incredibly well. And I think it's just another tool to put in our tool belt. Patients usually don't mind it. It's not an oil, right? So that IM shot isn't as painful for them. So I've had some good luck. So I would give it a whirl if you're willing.
All right, maybe something to add to my practice.
There you
But
go.
also just to say, what is our baseline idea of what a correct thickness is, right? What are we looking
Yeah.
for on that very first transfer? So some of it is going to be based on, how thick has a patient's lining ever gotten? How did they do during their stimulation? Did they get thicker than 4 millimeters with injectables? But on an objective level, I really would like to see in an ideal world 7 millimeters as my cutoff. I used to use 8 millimeters as a cutoff, but there's been some good data, and I'll be happy to share some of the studies that there are good success rates even with 7 millimeters. So that is my ideal cutoff. So if there was, I was not going to necessarily go with what she can do, but what I would like to see, I would say that my minimum that I'm looking for is 7 millimeters.
Okay. And are you mostly focused on the thickness, or are you focused on thickness and how the lining appears? And if you had to pick, which one would be, quote, more important to you?
So it is very important that the structure of the lining reflect what we call a trilaminar or 3-layer pattern. And honestly, that's more important to me than the thickness. So a thick lining with added trilaminar pattern, I will cancel unless there's something that I know that was maybe technically challenging for the ultrasound. But I need to see that trilaminar lining before I'm going to approve that patient for transfer. But the thickness there's some flexibility with that. And we can talk about some other cases, but I think in general, the structure of the endometrial lining matters more.
Yeah, no, agreed. And I think kind of what you're alluding to is in an ideal world, a patient would get greater than 7 millimeters. In an okay world, they would get 7 millimeters. But in real life, we have to find what that patient's personal best, lining is. And going back to kind of what we talked about at the beginning, this is where I think monitoring some of those cycles, it's nice because it just gives you more data points to say, hey, you've now tried letrozole, so we know that that's not going to be a great transfer cycle for you. And we know what your lining looks like during the IUI cycles with letrozole, which would be, similar to how we would do a potential modified natural FET, right? So you can go back and refer to that. So that's where I think having more of those data points initially is also potentially helpful.
I
Um,
agree. Yeah, I agree. And I think that it's very helpful to go back and even look at all the images. And sometimes I'll do that as an exercise when I'm evaluating a patient like this, is I'll just go through one by one, looking at all the ultrasound. can I see any picture that I'm happy with, that, that looks great? And if so, like, okay, we know that you can do this. But if every single ultrasound you look through and the lining at the maximum is 4 millimeters, that might be her personal best.
Right. Okay, so you've canceled this cycle. Are you going to do any further workup? Are we looking for other etiologies that would potentially cause a thin lining at this point?
So that's a good question. I would say I would have to talk with the patient at this point because it's only been one try. So I do have a workup that I do for thin lining, but I might try one more protocol before I do a workup. We've tried, for example, in this case, we did oral and vaginal, so I might try patches as another alternative before I start doing more of an evaluation.
Okay. So how many failed tries would you go through before you would go through that workup? And we can talk about that too, what your typical go-to workup for thin linings at this point are.
So I would give at least 2 tries personally to see, because I think that it's helpful for us to understand what is the patient's personal best when we do estrogen replacement cycles. And then I would consider thinking about etiologies. So when we're thinking about etiologies of thin lining, one thing that comes to mind is chronic endometritis, because we know that the inflammatory state of chronic endometritis can actually make the uterus less sensitive to hormones. And so sometimes I will do an assessment for that. I would probably at this point also do another hysteroscopy. I do hysteroscopies before all of my patients go to IVF. So I'm assuming that I would have already looked to make sure she doesn't have adhesions that could present as thin lining. But if it's been a while, I might do that again. And then the other thing that I would think of in this patient specifically is she has polycystic ovary syndrome, and we know she has elevated androgens. Chronically elevated androgens can actually cause the lining to be resistant to the proliferation caused by estradiol. So for her, we may think about whether lowering the androgens could be beneficial. So typically, this patient would not be a candidate for metformin, based on the data that we know from some studies. And originally it was the PPCOS1 trial that demonstrated to us that for PCOS patients, adding metformin did not help. Adding metformin to Clomid did not help improve live birth rate. But for a patient like this, even though she doesn't have pre-diabetes, or as far as we know, glucose intolerance, adding metformin and lowering their androgen level could actually have an impact on her lining if we do that for an extended period of time. And then we already ruled out congenital adrenal hyperplasia for her with the 21-hydroxylase test. And we also we did a 21-hydroxyprogesterone, and we also checked her DHEAS level. But there could be more subtle forms of congenital adrenal hyperplasia that would cause an elevated progesterone in the follicular phase. And we also know that high progesterone can impact an ability of the lining to respond to estrogen. So sometimes I'll also check a follicular phase progesterone level if we haven't already, to rule that out as a possible etiology.
Okay. So you've ruled all that out. Everything, of course, comes back negative. So at this point, are you trying a straight natural cycle to say, hey, let's just see what your body normally does? Walk me through your next steps.
So for her, we can't do a natural cycle because she doesn't ovulate. I would say in general, yes, I love looking at how the lining looks in a natural cycle to see maybe that is the patient's personal best. But we know that she doesn't ovulate, so we can't really do a natural cycle. We know how she does in a letrozole cycle. It's only 4 millimeters.
Mm-hmm.
Now we know how she does in multiple forms of replacement estrogen. So what I would do next would be a gonadotropin stimulated transfer. So in that situation, now she has a very high AMH, it is a robust responder. So I would start just with 75 of recombinant FSH, and I would try to get her to develop a lining that way. Now, part of that is looking at how she responded during her fresh stimulation. Because if she only ever got to 4 millimeters in her fresh stimulation, then she's probably not going to do better than that. However, in my experience, most of these patients do a little bit better in their fresh stimulation than they're doing in a letrozole cycle or in a programmed FET. So let's say she's 4 millimeters in her letrozole cycles, and her program cycles, maybe she's 4.5 or 5 millimeters on her fresh stimulation. Now that's her personal best, and I could try to mimic that by doing a gonadotropin stimulated frozen embryo transfer.
If her personal best was with the program cycle, would you go back to the program best at this point or to the program cycle?
Yes, I have transferred at 4 millimeters for patients for whom that is their personal best.
Okay, got it. So let's say you are teed up, you're like, hey, this is going to be the cycle, and you get to the point of doing the lining check, and you're like, I know it's not going to be super thick, but we know this is going to be the best you're going to get, and now there's fluid.
Yes,
Yes.
not the day that we are all hoping for.
That was definitely the ending we were all hoping for. So now what? Now what do we talk about? What are you thinking?
So, for patients that have thin lining, when they are exposed to excess exogenous estradiol, it's not uncommon that they'll develop fluid. So, for somebody who's developing fluid with all of that estradiol, I might actually dial it back and give them a lower dose because sometimes that's when I would actually do patches because it has a more steady absorption. It doesn't have sort of the highs and lows of an oral estradiol or vaginal estradiol. So sometimes that can help with the fluid. But then I also want to think about other etiologies. Like we mentioned, a hysteroscopy or testing for chronic endometritis could be helpful because sometimes chronic endometritis does present as fluid. And at this point, I'd also really want to be thinking about the fallopian tubes. Fortunately, she did her HSG in the beginning. We didn't see any evidence of hydrosalpinx, but sometimes patients come to us without a tubal assessment, right? They've gone to IVF straight for some other reason, and we don't necessarily know for sure they don't have a hydrosalpinx. And so sometimes that hydrosalpinx can present as fluid just from the buildup in the fallopian tube. So I would check that if it hadn't been checked before. Now, this patient also had never had any prior pregnancies or any prior surgeries that I'm aware of. But we do know that isthmus seals and C-section scars can cause fluids. That's also something that I would be assessing at this time.
Great. Yep, agreed. Do you ever look into not necessarily the fluid side of things? We're going to pull that off. That was a one-off. We ruled her out for all the things you talked about. Going back to the thin lining, do you ever look at other experimental options that are out there? I mean, there's always something. So things like Viagra, pentoxifylline, vitamin E, aspirin, GCSF, PRP, any of those things that are out there. Talk to me a little bit about whether or not you would entertain those or the pros, cons, what your thoughts are.
So the answer is yes. I think all of us have thought about adding some of these adjuncts at various points, and I think that some of them have some evidence basis to them. Some of them there are emerging medical evidence to back them up, and some of it we have to be a little bit creative about what has a rational basis, even if we don't necessarily have a solid evidence base for. So I have used Viagra, I have used pentoxifylline and vitamin E, I have used baby aspirin to various degrees of success. I think as I've gotten more experienced, and I think I'm now 10 years out from my own fellowship, I think that what we see is that no matter what you do, if the lining is thin, the lining is thin. And I think that I've taken more solace actually in some of the most recent data that's come out showing that even at low thin endometrial lining measurements, you can actually have appreciable success. So just to share a couple of those trials, I think they're really important. There's actually 2 large SART studies that were both published this year in fertility and sterility. And I encourage everybody to take a look at both because they are using similar data sets and coming up with slightly different conclusions. So the first was by Schmeich et al. With senior author Valerie Baker that looked at 244,000 FET cycles. And they found that increasing thickness up to 9 millimeters was associated with increased live birth. Great. We would love it if our lining was 9 millimeters. However, the chance of live birth at 4 millimeters was actually 28%. And 5 millimeters was 30%, and 6 millimeters, 35%. So that was compared to a maximum of 46 to 48% with optimal thickness, which they defined as greater than or equal to 9 millimeters. So if I was going to tell a patient, look, we have a 30% chance of success with this transfer, they would probably take that, right? Because if we cancel the cycle, that's a 0% chance of success. And then the other START study was published by Gingold et al. With senior author Sunita Jindal, and that found that the lining actually up to 12 millimeters was associated with an increased risk of success. But just similar to the other study, 5 millimeter success rates was about 30%. So I kind of, I guess at this point in my career, I focus, I think, less on the measurement than like we talked before on the trilaminar. And so I'm not as quick to use some of these other adjuvants as I maybe used to be when I really was really trying to get these linings thicker.
Yeah,
Um,
I agree. I think a lot of the data has really helped us hone in on, how hard, you're right, we should work to try to, I mean, you should always get to the patient to their personal best. I agree with that. But, and I think a lot of the times the adjuncts might help around like the edges, right? But they're not going to fundamentally change the biology. So you're limited on what they may or may not be able to do. And sometimes I think it's more a placebo effect for the patient. Hey, we're changing something. And we know that a lot of these aren't going to hurt, but whether or not we're actually physiologically treating the issue, I'm not sure.
Now, I do want to say something because we're talking about 4 millimeters. Now, 4 millimeters is pretty much the lowest I've ever done an embryo transfer at. What if the patient has a lining of 2 millimeters? Now we're in slightly different territory. And I think that I would consider some of these other treatments that you've mentioned. And I want to highlight one that actually we do at Case Western that was pioneered by my mentor and the former chairman of our department, Dr. James Liu. And he looked at actually at ophthalmology and saw that they were using amniotic grafts for eye surgery and thought, hey, maybe we could do the same thing for the endometrium. And so he started on an experimental basis using amniotic grafts to help patients either with significant adhesions or thin linings, and actually found significant success with that he published as a case series. And so we are continuing to offer that to patients. We also have a new amniograft infusion that we're in a clinical trial for right now. So I think that that's a really interesting option that I will offer my patients, if they especially for adhesions as a source of the thin lining or just sometimes for a thin lining. And I know there's some other treatments out there that I personally have not used, such as PRP or Neupogen infusion. Do you have any experience with either of those?
Yes, and I was on that case series with Dr. Liu, so I do know what you were talking about, the amniograph. Yeah, I was struggling to get it, so I'll have to loop back and see how you were getting it. And then when we lost that Cook catheter, because we used to wrap it on the Cook catheter that had that
Mm-hmm.
nice triangle shape, it was hard to do it on the Foley, so I kind of switched from the amniograft over to PRP. The amniograft was also quite expensive for a lot of patients, whereas the PRP in essence is free, right? I mean, it's their own blood. The risks are minimal. And as expected, it's experimental. The patients know that. But I also look at it like I'm already in there doing a hysteroscopy anyway. So it's not going to hurt anything. It's your own tissue. So um, it has worked in some patients, but who knows if it was everything else I was doing. You don't know until you get that RCT, which we don't have that data out yet.
Yeah, and just for the listener, so PRP stands for platelet rich plasma. And then do you just want to say a little bit about how that's actually prepared?
Um, yeah, so we take several tubes of blood from the patient, spin it down, and then you draw off the supernatant, the platelet-rich plasma part of it. And in essence, there are different protocols out there for PRP injection for thin linings. Nobody knows what the right answer is yet. Some people are just injecting it into the uterine cavity prior to transfer. I have not done that yet. Some people are injecting it subendometrial at the time of hysteroscopy, which is what I have done more so for patients also with adhesive disease, because the thought process being it would help with healing as you're trying to get them to heal before they rescar potentially. So that's more where I have looked at it than just the hardcore thin lining with no etiology. But it definitely is something to think about. Again, though, it gets back to why are you having a thin lining? So if it has nothing to do with that, putting the PRP in there is not going to be beneficial. So I think we're learning. I think I always tell patients in 10 years, I might look back and say, what the heck was I thinking? That was the craziest idea. Or we might say, we're doing it for everyone. A little bit kind of like the ERA, right? But Unlike the
Yeah.
ERA, it's less expensive and less invasive, and that's a whole nother discussion.
Actually, I'm glad you brought up the ERA. So the ERA, or endometrial receptivity array, was a very popular test. I don't know, however many years ago, to say the patient receptive to our program cycle before doing a transfer. And we have, I think, when we were kind of more using ERA before randomized controlled data demonstrated that it was not effective for increasing live birth in first transfer for patients, we were actually offering patients with thin linings an ERA. And then that would make us feel more confident about transferring, if with this mock cycle, the lining was only, say, 4 to 5 millimeters, but it was still receptive. But I don't know that we have any data to say that ERA is helpful in that context. And we've essentially stopped doing ERAs because of that other randomized controlled trial data. So I haven't offered this to a patient recently, but that is something that we used to do.
Got it. And just because we're on the topic, so why not? And we're talking about the endometrium. Do you ever offer it? What if they've had multiple failed transfers with euploid embryos? Is there any indication, do you think, for the ERA, or you just think based on what we know, it's no longer a helpful test?
It's interesting. I would say when we first started using the ERA, we actually did notice that we had a large percentage of our patients that were pre-receptive. And so we actually ended up changing our progesterone start time. We used to have them start progesterone in the evening. We changed it to starting in the morning for everybody. And at that point, we started to see fewer pre-receptive ERAs. And now that's a practice change that everybody does in our practice, right? Everybody is now taking their progesterone essentially 12 hours earlier. But we don't use the ERA anymore. So I think that the ERA actually in our practice was helpful in the sense that I think that it changed our progesterone administration for everybody. And I think overall our success rates went up. So I don't know that the ERA has no role. I think that the way that it's utilized in clinical practice to try to individualize embryo transfer was not shown to be effective. But for a specific patient in this situation, I think you could offer it with the caveat that we don't know whether having this test demonstrating receptive endometrium actually makes a difference for your specific transfer success rates.
Yeah, and I think another key point in this case slash every case is how many embryos do they have? Are they ever going to make more embryos, right? Like, what is the long-term plan? Because sometimes I tell patients what you're going to do 5 steps down the line impacts what we do today, right? So if you have one embryo, you might not be willing to transfer into this thin lining, which what are your other options, right? So if you can only get them to a certain lining, they have to decide, do they want to use their uterus, or I don't know. Would you ever offer a gestational carrier in that situation? Or would you say that's just not enough based on all of the studies that you just presented? It's worth trying in their own uterus.
That's a great question. I think in this case, it's a little bit more straightforward. I think you told me she had 5 euploid blasts.
Mhm.
I think, and she's 34, so she can make more if she needs to. So I think for her, I would definitely encourage her to transfer to her own uterus. Because like we said before, based on the studies from those 2 START studies that I showed you, there's actually another study from Human Reproduction that was published in 2025 with first author Genovese and senior author Selly, which was a multi-center cohort of over 30,000 cycles that were all euploid FETs. And they actually found similarly that linings less than 7 were less likely to be successful, but that the lining itself was not enough of a predictor of success to recommend cycle cancellation at any endometrial thickness. So I would try to reassure her that her success rates are still relatively high with her own uterus. But if we're not getting success, I would move on to a carrier if she had reached the point where she's like, I can't do this anymore. Now, the harder situation is a patient that doesn't have many embryos. You gave, again, like, thank you for giving me a relatively easier case, but what if she's 43 and she went through 5 retrievals to get
Mhm.
1 euploid embryo? Now what? So I think that's a case that is a little bit more challenging. And I think it would be a conversation with the patient. Look, this is what we see. 30% chance of success with the lining. Is that enough for you? And I do think that if the lining really can't get to an optimal thickness and there really is only 1 embryo, I can't say I've ever done a carrier in that situation, but I would consider it.
For your patient, at what point, let's say she has 5 embryos and she says, Dr. Moonman, I do not have the money to do another retrieval cycle. Like these are our 5 embryos, that's it. After how many transfers would you bring it up? Would you suggest it? Would you recommend it?
I think obviously I would be hopeful that the first two transfers would be successful. I think that would be my
Mhm.
minimum.
Mhm.
I think we have good data to say that after 3 transfers, most people will get pregnant successfully with a euploid embryo, and her embryos are euploid. So I would say, in my opinion, I would ideally like to give her 3 tries. Now, that would, in her case, reserve 2 embryos for a carrier. Now, here's the thing: if she can't afford another retrieval, she probably can't afford a carrier either. Um, which is unfortunately challenging. But I typically, if I am going to use a carrier, I like to reserve 2 euploid embryos because we know that even in the best case scenario, success rates with the carrier too are not going to be higher than 50 to 60%.
Yeah, no, I think those are all great points. It's definitely a tough situation. And I think this is where a lot of times I say, look, there aren't great data. And sometimes this is one of those situations where we just learn as we go, and sometimes we just have to try and see what works best for that patient. And it almost becomes, you're on the same team, right? So we're on a team here. We're both have the same end goal. There's no data to tell me this is the best protocol. It's going to be patient dependent. You're a human, right? And humans do different things. And frankly, they do different things with the same exact protocol. So we can only control what we can control. And you just, like we've talked about, you just try to get them to what their best chance is.
So curious what happens to this patient. I mean, my last protocol that I was trying was the FSH stimulated FET. Okay, so what happens?
She got pregnant. We'll give it to you.
4 millimeters, FSH stimulated FET for the win.
For the win, for the win. Absolutely. Absolutely. Is there anything else that you can think of in, kind of like we talked about at the beginning, right? So anything else in your workup, that we didn't talk about that you think is important to address?
So I think, first of all, thank you for this discussion. I really enjoyed it. I think that dealing with thin lining is one of the most challenging uh, diagnoses that we see just because we often don't know the etiology and don't necessarily have a great pathway forward for management. But I think that what you brought up is, ruling out treatable causes is really helpful. And I think that doing diagnostic hysteroscopies in these cases is very helpful because you can see subtle adhesions, chronic endometritis, or other things that you might not necessarily see on other imaging modalities. And I think that it's very important to work with the patient realistically to assess what their goals are. Because, like you said, every patient is going to have a different willingness to do something that may not be as successful. But ultimately, I try to reassure patients that the thickness, as far as we know, matters less than we used to think it matters, based on the more recent trials, and that success rates can be significant even at thin lining. So I try to give them hope. I try to give myself hope in these situations.
Yeah, and I think that's all you can do. So it sounds like you're saying step one, when you find a thin lining, is work it up. So rule out any treatable causes. Step two would be look at the different treatment protocols and figure out what that patient's personal best lining is. Try different types of program cycles, right? So programmed, natural, stimulated, kind of work the gamut to figure out what is going to be your ideal. And then depending on how many embryos you have, or if you transfer and it doesn't work, then you would start considering some of the more experimental options that are out there. Is that kind of a fair assessment of what you would do?
Yes, I think that's exactly right. And I think that, each center obviously has to assess their comfort level for some of these experimental treatments that might not necessarily yet have the evidence base behind them, taking into account the risks and the benefits and, the way that they would counsel the patient about those.
Yeah, absolutely. And then throwing in a little bit, because I know we said we talked a little bit about fluid. Fluid similarly, right? So you're going to rule out anything you said that you would treat, figure out the protocol that has the least amount of fluid that they would have. And then I don't think we touched on this, but let's say no matter what protocol you do, they have fluid at that lining check. Would you at that point add in progesterone and see if that transition over to the secretory endometrium is enough to reabsorb that fluid before transfer? And if not, do you aspirate? And if not, do you use a gestational carrier in those situations?
Okay, so good question. So first of all, I think we touched on this, but ideally, if I've ruled out all causes of fluid in the lining, I like to use the most natural protocol possible because I do think in a lot of situations it's the excess estrogen that's causing the fluid to accumulate. So if the patient does ovulate on her own, I would probably do a natural cycle, if not a letrozole cycle, or even an FSH stimulated cycle rather than a program cycle in that situation. And then, yes, if after repeated cycles we're still seeing fluid, I would start the progesterone and then have the patient get another ultrasound after the progesterone has started to see if that fluid has resorbed or resolved. Now that we have the progesterone effect on the uterine lining, which can counteract some of that, estrogen-induced fluid potentially. It's been rare, but on the situation where the fluid is still there, despite the progesterone, and there's really nothing else that we've done, and the patient really wants an attempt at transfer, I have aspirated the fluid the day of the transfer, and then taken the fluid out and putting the embryo in. And I will add with success, not obviously not every time, but I have had success in those cycles. I've had a couple of cases throughout my career where on the day of the embryo transfer, there's fluid that we did not see before. So, everything looks great on the lining check. The patient comes for her transfer. The embryo is thawed. Everybody's ready. She's in the stirrups. You do the transabdominal ultrasound, and the sonographer kind of gives you a little bit of a side eye. And she's like, Dr. Wienerman, did you see what I'm seeing? And in that situation, I've had to tell the patient, look, we see fluid on the lining. The embryo's already thawed. The lining otherwise looked great. I'm going to take the fluid out and put the embryo in as long as the patient is okay with that. And despite my feeling uncomfortable the first time that happened to me, actually most cases, I would say the success rates are just as I would expect.
Would you ever think to mandate scanning prior to embryo thaw or the day prior or anything like that? Or it doesn't happen enough that you think it warrants a clinical change?
I don't think it warrants a clinical change. I think that it's in my experience, it's few and far between. And I think it's already enough of a hassle for the patients to do all the lining checks that they do and come for all the blood work that they do. So I personally don't think that it's warranted. But curious if you've had cases like this.
Gosh, not recently, but I do know what you're talking about. And part of me wonders too if it's a different, I mean, obviously I don't know, but if it's a different physiologic process, the person who just every time they come in for their lining check has a puddle of fluid in their uterus versus someone who's never had any fluid and then maybe like, is it just a little mucus? Did it come, I feel like that is probably a clinically very different patient than the person who earlier on you've noted copious amounts of fluid. I don't know.
Yeah, it's a great point.
So awesome. Well, you had success here. You have success in lots of your patients. It is always wonderful hearing how you think and how you work patients up, especially in difficult situations such as the thin endometrium, fluid in the lining. Anything else that you would like to say before we close?
Well, I will just say I really enjoyed this conversation. And Gigi, I think you can give yourself a little credit too. If memory holds correct, I think you did your thesis research on endometrium. So it's been great to hear your clinical practice too. And I really enjoyed the conversation.
Oh, I always love talking with you, Rachel. I hope you have a great day. Thank you again for doing the MRSi podcast. I'm looking forward to hearing you speak at the MRSi board review course. Rachel gives amazing lectures during that. And then seeing you at the Midwest Reproductive Symposium International in July. I'm excited that I will be the president, and it's going to be a great conference. We have a lot of wonderful speakers, a lot of education, and it's a great opportunity to have discussions like this with colleagues.
So proud of you. I'm so excited for your presidency.
Thank you. Have a great day.
Bye.
Bye.
As expected, that was so enlightening. Thank you both, Dr. Wienerman and Dr. Collins. If you want to hear more, From Dr. Wienerman and Dr. Collins, join us at the 2026 MRSi in full bloom annual conference, July 26th through the 29th, 2026 at the Drake in Chicago. Our vision is to bring the world more babies by being a beacon of change, inspiring curiosity, pushing boundaries, advancing science, and uniting minds.